pericarditis. It's just a nice picture. It shows the esophagus, aorta, vena cava, ridiculously small vena cava. The vena cava is not that small. It's huge. It's about the size of the esophagus. But it's just a nice picture. I thought it would be nice to show you that, but no, you don't have to worry about that on the test. Here, that's just a description of the previous slide, that slide, so I circled it, nothing there. What's a function? We already talked about that. Here's a couple fancy words. External respiration. Now, I explained this, that the word respiration comes from microscopic exchange of oxygen at the cellular level. But we use the word to breathe, I'm respiring. But we call that external respiration, internal respiration. In order to distinguish between biochemistry and cell biology and gross anatomy, we say external, internal. That's the only point of that slide. Because, you know, it's a good word to use. Just good to know, because when you're talking to the patient and the doctors, they're not going to make that distinction. But when you're talking to the lab people and the experts, they're going to make that distinction.
If you want to, you could write on.
Why are we transporting O2 to CO2? Give me a good answer. I'll give you 3 bonus points. I've already told you who wants to earn 3 bonus points. Why are we breathing? What do we do with oxygen? Remember we had a long discussion about that?
Correct cycles.
You back around on that one a bit? Yes, ma'am.
If you have to make more energy, you can do it faster, or you can make more energy.
And where do we make that energy? Oh, because I said my dear, you all think they're my dears, and you all answer. So she's my only dear. Well, too bad. She's going to get no points. Right, you're using O2 because the oxygen is used as an electron sucker in that electron transfer chain, which goes on in the mitochondria, and you make a whole lot of ATP. Without it, you'd have anaerobic glycolysis without oxygen, and you'd only make 2 ATP. But with oxygen, in the mitochondria, you can make 38 or 36. Actually, 52, but the book says 36. All right.
Which one do we need to know?
Neither. There you go. Blah, blah, blah. There you go. All the parts of the... we went through that. We drew that all on the board. Thank you very much. Thank you very much. Same thing. Reproducing slide. Same thing. We covered that, covered that, covered that. Oh, there's cilia. I did mention it a long time ago, but I forgot to mention it again. When stuff goes down your trachea and your bronchi, bad stuff, like, hey, I'm doing plastering in a house, or I'm doing insulation, fiberglass, little fragments are getting in my lungs, the silica is inert, the body goes, we can't digest that, that's silica, I can't break that down. So the cells wave it back up and go, get that out of here. Like brooms, they wisp it back up and it comes out of your throat and you spit it up locally the next day. If you don't, the white blood cells eat the silica and they go, I can't break that down. So another red white blood cell eats the white blood cell that ate the silica and doesn't work. And then another white blood cell eats the white blood cell that ate the white blood cell that ate the silica. And another white blood cell eats that white blood cell, goes on indefinitely, and you end up with a big little bead in your lung that causes cancer. And then you get, of course, cancer, you know, from asbestos and fiberglass, shrapnels and all that stuff. Because it just irritates the hell out of the lung, and then it can trigger cancer. We talked about that. This is a much nicer picture than the one I drew. There's your Adam's apple. Right there. See? You can feel a little notch. And there's the hyoid bone, there's the cricoid ring. This part and that part is your voice box. When you're doing a tracheotomy and you want to stick a pipe in there to let air in there because something's stuck in your voice box, please don't cut it there. That's where your vocal folds are. When you're measuring down, put your finger here on your Adam's apple, right there, your finger's there. Move down, you can feel that. Okay, I got the ring, I got my finger on the ring. There's the ring, I can feel it in my throat. Now let's go below the ring. Okay, below the ring, there's the trachea. Or work backwards. Put your finger down here on the jugular notch, right on the sternum, on the maneuvering. Then take your finger and take another finger and lay it right on top of your other finger. And bingo, you're right there. That's where you do a tracheotomy. Your first finger's here. Here's a jugular notch, the manubrium. Lay your other finger right on top and bingo, you should be right here or right here. That's where you cut for a tracheotomy. Any chance one of you might start choking in here and Heimlich maneuver doesn't work? Because I'd love to do a tracheotomy. Every time we go to a restaurant, I just keep looking over. Are you choking? Are you choking? I run over with a knife. That's just an experience I want to have. You don't want to stick a knife in somebody's throat. Actually, you use a tube of, I'm just kidding, you use a pen. If you ever carry a pen around with you, and you pop out the insert, and you puncture that in, they work real well. Pen. I wouldn't use a knife, but I'd like to see if I can do it with a butter knife. All right, so there's a side view, and it's much too complicated to talk about. Very complicated. Now, the vocal folds actually run on a slant from here to here on an angle. It's hard to see. These little bones actually make your vocal folds come together and apart. They tighten it so that you get high pitch when it's tight and low pitch when it's wide apart. Now, these little bones, when I was first in college like you, well, it's really funny. A lot of people couldn't talk, and the doctors would cut them open and look at that, and they'd go, oh, the bones, they're not moving. You know, like windshield wiper blades. Watch. If you have two bones rocking, moving like that, see, and you imagine the vocal folds in between, I'll draw it for you. Here, watch. See the two little arytenoid bones, and here's the vocal fold, see? As the bones swing out, that would get wider apart, and as the bones move in, it would get closer together. Well, up till 1975, that's what all doctors thought. So they opened up the throat, and they cut the little arytenoid bones, broke them, because they weren't moving, and they dropped pins in them. Well, all those people permanently lost their voice forever. Because Dr. Fetterman, my teacher, wrote a book on it, and he goes, uh-oh, all these years we thought they moved this way. They didn't. They rocked back this way. Imagine a ring, a round ring, and you got two bones like my fingers rocking back. You see how when they rock back they get wider apart? And when they rock forward they move in? So these little guys rock back and forth. They don't swivel left to right like windshield wipers. They rock back and forth. So all those people, I forget how many thousands of people had that surgery done, turned out not to work. Well, that's why we didn't understand that those little cartilage, they're actually cartilage, called the arytenoid cartilages. And the little muscles on the back rock them back and forth. That's an interesting clinical story to show you, even as late as 1970s, although we thought we knew everything about anatomy, we had dissected the body and all, we were still making horrible mistakes. Arytenoid cartilage, that was another story about it. Valsalva's maneuver versus Heimlich maneuver, what's the difference? Heimlich is go up to somebody and squeeze. Why are you squeezing? To make the chest cavity smaller. What will that do?
Force out the
Make pressure go up. Pressure goes up, what's it going to do? Try and force out whatever's obstructing it. So what are you doing? You're pushing on the abdomen, squeezing in the gut, pushing up the diaphragm, making the chest box smaller. If you make it smaller, the pressure goes up. Pressure goes up. Hopefully the food pops up. How is that different than Valsalva's maneuver? What's Valsalva?
Bless you.
Pop your ears. Well, let's talk about the lungs. What's going on in the lungs with Valsalva? You're simply closing the vocal folds. So you're taking a bunch of air, and then you close the vocal folds, and then you apply pressure, just like you're getting Heimlich, but you do it yourself, and you make your chest cavity smaller. Then you force real hard, put a lot of pressure on your chest and your vocal folds.
I think.
Why would you do
When you're doing
Valsalva? I don't know. Helps to
I
empty
over
the
for it.
rectum.
Trust me. I did the right thing.
It stabilizes the body trunk during heavy lifting.
The sneeze I did get though. It was classic.
This is a repeat, no problem. This is really good. We drew this. There's a cartilage ring. There's a bunch of muscle. Here's all the ciliated columnar epithelium that wisp garbage back up again. Here's your esophagus. I believe you looked at this in slides, right? They all show me the cartilage and the cilia. There's the trachealis muscle, major muscle. And when it constricts, this is going to get considerably smaller in diameter.
Yeah.
Expect to see a picture of that on your test. Here's some nice cilia. This is a beautiful picture of the cartilage, mucus glands, and here's all the little cilia on top of the columnar epithelium. And here you see some multiple layers of cells. Well, that's pseudostratified. That means it's not So what's going on? Well, here's what's going on. The cells are like this. You got a tall, whoops, I'll draw it over here. You got a tall cell, columnar cell, like this, and another one like that. And then you got a cell squeezed in the middle. Here's the nucleus, here's the nucleus. So it looks like two layers. One layer, two layers. But they all are one layer. In other words, it's just one layer. There's no cell on top of that one. But it looks like it's two layers. And what's that cell? A mucus cell. Goblet cell. Making mucus. There's mucus cells squeezed in there to produce mucus to keep your throat moist. That's where pseudostratified comes from. It's a nice slide. It shows, hey, wait a minute. The right side has 3 lobes. 1, 2, 3. The left side only has 2. If you damage a lung, you can remove a lobe. Instead of throwing out the whole left or right side, they can segment the lobe and just remove that lobe. What happens if you remove a lobe of the lung? Does it grow back?
Yes.
Yes, it does. Good for you. Lung tissue can regenerate. This is really nice. We drew this, but this is a better drawing. This shows all the muscles wrapped around to make the bronchioles constrict. It also shows the little rubber bands all over the alveoli, the little sacs. 300 million alveoli. Wow, big number. This is what that would look like if you made a slice of it. It would look like that. Now, if you saw that, you'd go, what is that? Could be fat. Fat looks like that. Could be a gland. Could be the thyroid gland. I mean, geez, it'd be hard to tell that. They're called lookalikes. And it would be hard-pressed. You'd have to be a really witty histologist, very much on your toes, to look at that and know that was lung. We used to pull a trick. No, never mind. This is a great drawing. But students always go, what's going on over here? That has elastic, that has blood vessels. That doesn't have blood vessels, that doesn't have elastic? Yeah, it does. The artist should have said, hey, look, over here I'm just showing the blood vessels. Over here I'm just showing the rubber bands. But they both have both. But they don't say that. And tons of people look at that and they go, oh yeah, these have rubber bands and theirs have blood vessels. No, they all have both. It would just be too difficult to draw both in the same picture, on the same area, I should say. This is a real true blue tissue scanning electron micrograph, three-dimensional, very three-dimensional looking. And you see the alveolar sacs and all the elastic fibers all over it. Pretty cool to see it. No, this is not on the test. Only the stuff in yellow is on the test, and on this one it's just for your own edification. This is really nice artistic rendering of that alveolus sac and all the little cells, simple squamous cells, and some other interesting colorful cells. Some of them are macrophages, some of them make surfactant. What the heck's the name of the surfactant cell? Oh, that's why I can't remember. It's called type 2. I can't remember the name. Type 2. Oh, boy, that's a good name. I can never remember that name. Mechanics of breathing, inspiration, expiration, how we breathe. I just did all that. Pressure changes. Pressure varies. You don't have to worry about the formula. Just pressure varies inversely with volume. What does that mean? Volume goes down, pressure goes up. Volume goes up, pressure goes down. It's inverse, right? Volume goes down, pressure goes up. Volume goes up, pressure goes down. Yep, you got some intercostal muscles and you got the diaphragm. That's what makes you breathe. Don't have to worry about that. Expiration, again, intercostal muscles, diaphragm. This is simply telling you what happens when you breathe. So just read through that on those 2 slides. It's kind of obvious, inspiration, expiration, one's expanding, one's shrinking. I think you know this already, but quiet expiration and quiet inspiration, that's just a normal, like when you breathe in and then you just normally breathe out, you don't have to have any muscle activity. It's just a natural elastic recoil effect. common sense. Don't worry about that slide. I need to pull that slide out. All right, respiratory volumes. Barometry, that's the device used to measure the volumes. Not a sphygmomanometer. Anybody know how to say that? Sphygmomanometer. It's not a sphig, it's a spheroid. All right. You can ignore that. That's just telling you, minute ventilation. That's all on the other chart, so don't worry about that. Here, the only purpose of this slide is to show you that, male versus female, that men have larger lung capacities in every respect. Every number. Yet, well, except for tidal volume. And yet, women have better tolerance, endurance, and stamina than men, so that kind of surprises me. But men have better volume. But yet our tidal volumes are the same. In other words, when you're sitting there at rest, just breathing normally, you're breathing the same amount of oxygen as us, pretty much the same volume. But we have a much greater lung capacity. I don't know what that means, but I wanted you to know that's true. All right, all of these are simply duplicate with that. So you can just, all the other slides are all those, I don't know, I should just take them out and not confuse you. You have a separate slide for each one of those. All right, that's nice. It's good for studying, like flashcards, you know? And so I thought I'd keep them in there. But I just want you to know what these are. I'll give you a multiple choice test, and you just match them, you know? Matching, multiple choice, something like that. It's kind of self-evident. If you read this carefully, maximum amount of air that can be inspired, inspiratory capacity. So most of them are pretty easy, but every once in a while you can get tripped up on it. So give it, 10 minutes, make sure you got them straight in your head. There's a nice little curve, we just did that. Hopefully you named all of those. This is what I was looking for you to do. Bracket, 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 that's all. So if you did that when you turned it in. This is really nice. The point of this slide is a great critical value. Great value. A couple things I want to say about this slide. What do you notice up there? You notice that in normal breathing, your effective ventilation is 70%. That means how well you're passing oxygen and CO2. In slow, deep breathing, you know what that means, slow, deep, it goes up to 85%. But in rapid shallow breathing, it drops precipitously all the way down to 40%. So if somebody comes into your house or in an emergency room, they're going,